Hi friends, let's have a look at this short case scenario where a 70-year-old female comes to the emergency with complaints of colicky abdominal pain along with multiple episodes of bilious vomiting along with distension of the abdomen and constipation. On examination, the patient seems to be dehydrated and patient was given IV fluid. She was put on NG tube. And on further taking of the history, she tells you that she is also having a history of chronic pain which used to occur in the right upper abdomen, and this pain used to occur more commonly after having heavy meals. So whenever she used to have a heavy meal, she used to have pain abdomen, for which sometimes she even used to take some painkillers. But she never went to a physician for this chronic type of pain, and it was a neglected type of pain. Now this patient, after stabilization of the patient is being sent for an X-ray abdomen in erect and supine position. So what is the finding on the X-ray is you find multiple air fluid level in the X-ray abdomen with a cutoff point in the terminal ileum. And also you notice that there is gaseous shadow in the biliary tree. So what is the most likely diagnosis and how we are going to manage this patient? So friends, what we are dealing here right now is a patient clinically having all the features of intestinal obstruction, which is also supported by the X-ray features of multiple air fluid level. So she is having acute intestinal obstruction. But what is the cause of acute intestinal obstruction? What we notice here is one, chronic history of right upper abdominal pain. Second, what we notice is that there is a gaseous shadow or gases present in the biliary tree. So is there any correlation between the gaseous shadow present in the biliary tree and the acute intestinal obstruction? The answer is yes. Most likely this patient is having gallstone, which is chronic type of gallstone, and she's having all the features of chronic cholecystitis. And in the meantime, what might have happened is the gallbladder came into contact with the duodenum, and slowly there is a fistula tract formation between the gallbladder and the duodenum, and the stone migrates from the gallbladder to the duodenum through this fistula. And this stone, when it goes to the duodenum is a wide structure, so no problem. But when it reaches the terminal ileum, most likely near the ileocecal junction, which is a narrow point, it obstructs the lumen of the intestine and giving rise to the clinical picture of acute intestinal obstruction. Regarding this gaseous shadow in the biliary tree, because there is a fistula formation between the gallbladder and the duodenum, some of the gases leak from the duodenum and goes into the gallbladder and biliary tree. That is why we are finding the gaseous shadow in the biliary tree. So this condition is known as gallbladder ileus, which is a misnomer because it is a dynamic type of intestinal obstruction, not a ileus, it is a misnomer. And this condition occurs in a patient who is having chronic history, long history of gallstone, and the reason is the fistula formation between the gallbladder and the duodenum, which is the most common site of fistula formation. Sometimes there may be a fistula between the gallbladder and the colon also. How we are going to manage this patient? As this patient is having acute intestinal obstruction, first we need to take care of the patient's vitals, because patient is dehydrated. We need to give him IV fluids. The patient needs to be put on NG tube, and once the patient is stabilized, she needs to be taken for laparotomy. The intention of the laparotomy is to remove the stone by doing an introtomy. Introtomy means opening the site of the obstruction, opening the bowel at the site of the obstruction and removing the stone. What about the gallbladder? Some of the surgeons, if the patient is stable, they prefer to remove the gallbladder in this setting only. But most of the surgeons, they are not in favor of removing the gallbladder right now. They just do a laparotomy, removal of the stone, and taking care of the obstruction. And the gallbladder is being taken care of, usually taken care of afterwards when the patient is stabilized and once the patient is taken care of the intestinal obstruction. So most of the surgeons, they go for management of gallbladder or gallstone later on, once the patient is cured of this intestinal obstruction stage. So the ileus. Sometimes if the stone is calcified, you may also notice on X-ray the stone which is visible in the right lower abdomen. But if the stone is not very much calcified, you may not find it on X-ray, and even sometimes CT scan can diagnose a stone in the right lower abdomen. This is all about, in short, and about gallstone ileus. Thank you.